our next speaker, Dr. Michael Retsky from United States of America. Yes, Dr. Michael, you can share your screen.
Yes, hello everyone. Thank you for inviting me to speak at this conference. I am going to discuss a research project that's been going on for a very long time, at least 25 years. I'll discuss all that. I have a PhD in experimental physics. I am currently at the Harvard School of Public Health, and I am shortly to switch to Beth Israel Deaconess Medical Center, another Harvard university. Okay, this project was funded by NIH and the Komen Foundation. I have patents pending, and most of what I'm going to discuss is issued. Most of what I'm going to discuss is covered in this paper that I published with my colleagues last year, and I wanted to show you the co-authors in this paper. Dema Kelly is an MD, PhD. Bill Reshevsky is a medical oncologist. Ted James is a breast surgeon. Rick Rogers is a scientist in imaging. Michael Baum is a breast surgeon, retired breast surgeon. Jayan Vieta, another breast surgeon. Saro Erhabor is a laboratory scientist from Nigeria. Patrice Forget is an anesthesiologist. He was in Belgium, he is now in Scotland. So there is a wide variety of scientific and medical knowledge presented here. I published a book, I edited a book that was published by Springer. This is 3 years ago, it was published, but they pretty much ignored it. And then a few weeks ago, it got a lot of attention, and they advertised it on the front page of the New York Times a week after the presidential election. So I guess I'm getting a lot more attention than I was 3 years ago. Okay, this project started in 1993. I was attending a breast cancer research study in Europe, 1993, and there were two databases presented. One of them was from Italy, Romano Dema Kelly from Milan, and Michael Baum from UK. They were each discussing a bimodal relapse pattern in breast cancer data. I'll show you this in detail, but just for starters, it's 1,173 early stage patients with no chemotherapy, just mastectomy only. There was a sharp peak at 18 months and a minimum at about 50 months. And then it started up again with a broad peak at 60 or 70 months with a long tail extending to over 10 years. This has now been identified in 21 databases from US, Europe, and Asia. There are more than 21, but I stopped counting them. Okay, these are the Milan data for postmenopausal patients presented in relapse hazard. Relapse hazard is the probability of patient undergoing a relapse in a 3-month window if they enter that period relapse-free. So relapse hazard of 0.02 means that 2% of the patients who are disease-free at that period of time had a relapse in the next 3 months. So you can see there's a sharp peak at about 18 months, then a minimum about 4 years, and then this broad shallow peak starts up at 5 years and goes on to past 10 years. We're not sure what that 100-month minor peak is. It could be noise or it could be important. Okay, that's the postmenopausal patients. These are the same thing for the premenopausal patients. And what you see is that first peak now seems to show structure. There's a 10-month event and a 30-month event. Everything else is about the same. And by the way, these Milan data, I have a lot of experience with breast cancer databases, and I trust these data. And it's mainly because one person, the database manager for the project for this data since its inception, Benucci Valagusa. was the person. Okay, these are the same Milan data, but shown in the more traditional disease-free survival format. This was presented in the New England Journal, 1995. And what you see here is all patients are disease-free at time 0. And then there's a rapid drop off, and it seems to reach a plateau at about 5 years. And then it seems to start up again. It's sort of like a little ski jump. That's not an anomaly. That's the change in the early relapses and the late relapses that we see in the Milan data. Dema Kelly and I got together afterwards. We decided to collaborate. And my background is in experimental physics. I have a PhD in physics from the University of Chicago, and I was pretty competent in the use of computer simulation to study cancer growth. So this describes our collaboration. I was going to take the Milan database, the Bonadonna-Vallagusa database, and Dema Kelly's model. Dema Kelly has an MD PhD. He did a lot of work in analysis of animal model tumor growth. He said that the simplest description of tumor growth is that it starts off as a single cell and it can stay dormant for a variable period of time. Once it starts to divide, it gets to be an avascular micromet, and it can stay at that level for a variable period of time, and then all of a sudden angiogenesis occurs, and it grow up to be a detectable tumor and a lethal tumor. So my aspect was I was going to take their Milan data and Dema Kelly's model and try and understand the meaning of those variable peaks. This has been described as a detective story. Okay, this is what I found after doing some computer simulation of that. I found that the 10-month peak corresponds to surgery-induced angiogenesis. There were patients who had avascular micrometastasis, and something happened at or about the time of surgery to induce angiogenesis, and these showed up as relapses 10 months after surgery. The 30-month peak were single cells that were dormant, and they were induced into division and underwent angiogenesis stochastically and showed up as relapses at 30 months. And then those were all the iatrogenic events. The peak at about 50 months corresponds to when you first see the benefit of mastectomy to reduce probability of relapse. And in quantitative fashion, that 10-month peak, avascular micromets induced to vascularize. This is really prominent for premenopausal node-positive patients. It shows up in all categories, but mostly for premenopausal node-positive patients. 20% of those underwent this relapse mode. It was 5-to-1 node-positive to node-negative, and 2-to-1 premenopausal compared to postmenopausal. The 30-month peak were single inactive dormant cancer cells, and they were induced into division and then vascularized stochastically. And the combination of those two relapse events was by far the biggest part of the breast cancer problem. 50 to 80% of relapses were in those first two relapse modes. The late peak, past 50 months, is more or less a natural history of the disease. Just as a side issue here, to show how confident I am in the science that I'm doing, I was diagnosed with stage 3C colon cancer in 1994, just about when this project got going. And based upon my knowledge of tumor growth and what people talked about, down-person kinetics, I ended up deciding against maximum tolerated chemotherapy. Instead, I became the first person to use metronomic chemotherapy, low-dose long-term therapy. This was designed by Bill Retsky, who was one of the co-authors, and this is published in ProPublica, the whole story about my use of early of metronomic chemotherapy. These are data from Bernie Fisher. This was another very prominent breast cancer researcher. He died a year or so ago at age 100. These are disease-free survival data for patients with mastectomy only, grouped by nodes positive, no chemotherapy at all. And the curve on top are for the 0-node population, and the curve on the bottom is for those with more than 12 nodes positive. And let me just describe what I saw in the 0-node positive. First of all, simply removing the primary tumor cures 80% of patients. They will not have a relapse. But of the 20% who relapse, about 10% of them relapse in the first 3 years. Then there's a period of several years where there's very little activity, and then it starts up again very slowly with general relapses for the next 10 years. And finally, at 10 years, all 20% of those have relapse. Now, going down to the worst prognosis case, the number with more than 12 nodes positive, the same general pattern occurs, but the magnitude is far different. For example, all the patients relapse eventually. Prognosis of 12 and more nodes is a very serious prognosis, especially before use of chemotherapy. But the early relapses seem to show up in the first 3-year period. Instead of 10%, as in the 0-node patients, they're about 90% for the 12-node patients. And then there's a period of a few years with few relapses, and then it starts to go up again. Now, the timing is exactly the same between the 0-node population, I don't know if you can see my cursor, and the 12 and more node population. It's the magnitude is different. And then there's this period with few relapses, and that's in both cases. This was very helpful information. Okay, I've been studying a lot of cancer data, and I can tell you that I've seen this general pattern in many, many cancer types. I don't think there's one cancer type that I haven't seen this. These are combinations of large databases or case reports, pancreatic, melanoma, lung cancer, prostate, on and on. I think every cancer I've looked at, the solid and the liquid cancers, also something similar to the bimodal relapse pattern. Okay, my colleagues and I were wondering, these effects are so large, they should show up in clinical observations. So we took a careful look at adjuvant chemotherapy. It turns out that adjuvant chemotherapy works best by far for premenopausal node-positive patients. And that makes sense because those are the patients that have the most intense tumor growth right at the time when they discovered that adjuvant chemotherapy works best by far. And the co-authors in this paper, 2004, were Folkman. I was on Folkman's staff at the time at Harvard. Bill Retsky, who, as I mentioned, was the medical oncologist I used, and Gianna Bonadonna, who was the person from Milan, who was very prominent, and he was the first person to use multiple chemotherapy drugs in breast cancer. And this is Panuccia Valagusa, the last author. So everyone seems to agree on this, that this could explain why adjuvant chemotherapy works particularly well for premenopausal node-positive patients. And then looking at mammography, it turns out that mammography works better for women age 50 to 59 than 40 to 49. And we've done a lot of work in this, published a number of papers, and we can quantitatively explain this data. I want to point out one paper. It was published in 2005. This paper was published in a reporter from the Wall Street Journal happened to hear about this, and she wrote a report in the Wall Street Journal that was issued on the same day of this 2005 paper was published, and Harvard issued a press release on the same day. We got a lot of attention. And one thing in particular, I got a letter to the editor from Isaac Lucas. Isaac, who died a few years ago from cancer, originally from Nigeria. He was a surgeon practicing in UK at one of the hospitals there. He said, this could explain what they see in Nigeria. And I spent a lot of time talking to Isaac Lucas about this. he said a lot of women, when they first find a tumor, they have known that surgery to remove the tumor causes it to come back very soon, very soon after that. And the word he used was, they believe that the surgery provokes the tumor. So what people do in Nigeria is they generally go to an herbalist and get some soothing ointments instead of getting a mastectomy from a surgeon. And so we could quantitatively explain the mammography data from the Milan data, and this also explains the situation in Nigeria. I'll get back to that. There's a racial disparity in outcome. In the US, there's an excess mortality of African Americans compared to European Americans by about 1.5. However, this inverts at age 57. If African Americans are under age 57, they have a poorer outcome, but if they're over age 57, they have superior outcome. So you can't blame this on poor access to quality medical care. It's got to be biological. Published a number of papers on that. And also, breast cancer is considered to be aggressive in young women. Well, from the physician's point of view, they remove the primary tumor and you get a relapse 10 months later, and they say, well, that's an aggressive cancer. But from our perspective, it's clockwork relapse, surgery-induced angiogenesis of dormant avascular micrometastases, showing up as relapses at 10 months. I happened to run across this paper, Irving Ariel, Historical View of Breast Cancer Treatment, and I was sort of surprised to see that Irving Ariel looked at the history of reporting of breast cancer from the ancient surgeons and physicians. He looked up what Celsus and Galen reported 2,000 years ago. And these are quotations, but it's been translated several times, so the wording may not be exact. Celsus first says there's a cacoethes, then carcinoma without ulceration, then the fungating ulcer. None can be removed but the cacoethes. The rest are irritated by every method of cure. The more violent the operations, the more angry they grow. After excision recurs, bringing with it the cause of death, whereas by using no extirpation, protract lives notwithstanding the disorder to an extreme old age. That's relative to the lifetime survival in that part of the world. And Galen said something very similar. We have cured this disease often in the first stages, early stages, but after it has grown to a noticeable size, no one has cured it with surgery. So after reading this, it was clear that Celsus and Galen knew all about this 2,000 years ago, but somehow this got lost. This got forgotten. We are latecomers to this very old 2,000-year-old problem. So at this point, I'd say the most important finding was that something seems to happen at or about the time of surgery to precipitate an early wave of relapses, accounting for over half of all breast cancer relapses, and surgery induces angiogenesis of dormant avascular micromets and starts growth from single cancer cells. And this may be a general effect, not just limited to breast cancer. June 2010, a paper was published that opened up a lot of research for us. This was Patrice Forget from Brussels, Belgium. He is now in Scotland, but at the time he was in Brussels. This was at a teaching hospital, so they have to expose all the residents to the various drugs used in anesthesia. And what Forget did, he did a retrospective study. He looked at the last 320 consecutive mastectomy-treated patients, chemotherapy in addition, mastectomy and chemotherapy, treated with one surgeon and given conventional therapy, and grouped the outcome by what drug was given at anesthesia. And to his surprise and everyone's surprise, one drug was far and away superior. That was the only NSAID available that was IV administrable. There are 2 other NSAIDs available, but at the time that was only one. There was a 5-fold reduction in relapses months 9 through 18 for ketorolac, the only NSAID that they used as an analgesic. Okay, so at this point, we knew something at the time of surgery seemed to cause these early relapses. Something, if you want to prevent the problem, something would be needed to stop these relapses at about the early, before the surgery. But what mechanism could explain that Forget data? And I'm quoting here from a quote from Hiller et al. The perioperative period can be considered a perfect storm of immunosuppression and inflammation in the presence of residual or circulating tumor cells. So we took a survey. These are very involved, very large subjects, and I realized that this was an impossible project. We took a look at these following 6 subjects to see what the correlations are among them. Surgery, inflammation, there is IL-6 elevated for about a week after surgery for breast and colon cancer. Angiogenesis, it's known that platelets actively sequester angioactive factors and they degranulate in the presence of inflammation. VEGF is elevated in serum, platelets are decreased by about 10%. Circulating tumor cells are well known for cancer patients, and it correlates with outcome. The immune system is well known to be compromised with inflammation, and cancer dormancy is a well-known effect in oncology. Just listing a few of these things, Virchow in 1863, chronic inflammation leads to tumor growth. Dvorak in 1986 describes cancer as wound healing gone awry. Weinberg, 2005, cancer usurps the wound healing process. This was an important one. Balkwell et al. In Lancet, 2001. If genetic damage is a match that lights the fire of cancer, then inflammation is a fuel that feeds the flame. So if you want to remember one item from this talk, I would say Balkwell would be it. Krebs and Z, it's well established that cancer patients have circulating tumor cells, and the quantity of circulating tumor cells correlates with prognosis. It turns out that daily aspirin reduces risk of late relapse after 2 years of use. I got involved in this. There was a paper that was submitted by El Sagar et al. This was a case report of a gentleman who was diagnosed with inoperable lung cancer. And he was released from the hospital after radiation, had a horrible prognosis. He was driving his car and he bumped his head on the head visor, and within a month, a 7-centimeter tumor grew at that spot. So El Sagar submitted a case report suggesting that this might be what Dema Kelly and I had been writing about. So I was asked to review this paper, and I was able to look at it, and I came to the conclusion that that case report was not what we described as surgery-induced tumor growth. Something else must be going on. Someone pointed me to this paper of Martins Green et al. This was a paper that described an avian root sarcoma virus in circulation, and they found that the tumor would grow at any site of wounding, and they could prevent this with inflammation. If they allowed inflammation, they could wound the bird anywhere and you get a tumor growth there. If they prevented inflammation, the tumor would not grow there. This is sort of like that El Sagar study, except a virus is maybe 1/100th the size of a cancer cell, so it's not a great correlation. Jones and Rue, 100 years ago, the localization of secondary tumors at points of injury has been so often remarked upon, that it's unnecessary to cite specific instances. Cause unknown. This was at a time when people walked around with cancer far more than today. A couple case reports, Walter et al., 2 patients with squamous cell carcinoma of the lung. They had distant metastasis at points of injury. Blood speed in capillaries is 0.5 millimeter per second. compared to 40 to 50 centimeters per second in large arteries. So if you have leaky capillary venules, that could be an efficient way for circulating tumor cells to get trapped in a distant organ. Pascal and Perez-Rivest et al. Inflammatory response after resection for colon and breast cancer. IL-6 marker for inflammation. This marker is elevated in serum and decays to baseline after about a week. Metastatic process is highly inefficient. Malignant cell injected into circulation has 10 to the minus 4 probabilities to result in a growing metastatic site, but inflammation can bypass the need for extravasation through an intact vessel wall. That's a very large effect. Delekas et al. This is an important paper. They were looking at the data from Norway on patients, breast cancer patients who had reconstruction at variable times after the primary surgery. When they looked at these data, the relapse data, with time 0 set to the original time of surgery, they found that bimodal relapse pattern that we see, but then they set time 0 equal to the time of delayed reconstruction, and they still got the bimodal relapse pattern. So this says it's not the cancer surgery that causes it, but any surgery. Clement et al., I know her from Harvard. Platelets actively sequester angiogenesis regulator and degranulate with inflammation. There's a 10% dip in platelets and corresponding increase in VEGF. This first item was chapter 4 in that Springer Nature book that I wrote I edited with Emma Kelly. After reading this chapter, these are anesthesiologists. After reading this chapter, I would be surprised if surgery did not cause tumor growth. You can look at that paper that's on my Harvard website somewhere. Neutrophilic extracellular traps. These are webs that are cast out by neutrophils that are triggered, that are induced into extensive growth, extensive numerical enhancement after inflammation or wounding or anything like that. And these sort of neutrophilic cellular traps, these are web-like structures that come out from the DNA of a neutrophil, and they can capture circulating tumor cells. And since neutrophils have the ability to extravasate easily into a tissue, they can carry these cancer cells with them. And that's discussed in that chapter 4 by Hiller et al. And a couple other papers discuss that. This was an animal model study done by MIT, Kral et al. They developed an animal model, a mouse model, where they could inject cancer cells into this mouse model. And if the mouse had an intact immune system, these cancer cells would go into dormant states. If the immune system was not competent, then these dormant states would not happen. But they could operate on the animal on one side and get tumor growth on the other side, and vice versa. This was reviewed in Komaroff in New England Journal. Another animal model study, this was from Harvard group, Panigrahi et al. This is the first sentence in their paper. Cancer treatment is a double-edged sword, as surgery, chemotherapy, or radiation can induce tumor dormancy escape and metastatic outgrowth by, you can read it yourself. They're saying that all three interventions, surgery, radiation, and chemotherapy can induce dormancy escape. So cancer treatment is a double-edged sword. Recent papers that I found, Lipitz and Harris talked about IL-6 as a prognostic factor for relapse in many cancers. And Kida et al., it's IL-6 is a prognostic factor for lung cancer, but on post-operative day 1. So if you want to know when these events are important, it's post-operative day 1 is when inflammation is an important factor. I now think I know how to prevent the late relapses. I patent is pending, and I submitted a paper a few weeks ago. It has not been published yet, but that's an extremely simple procedure. Conclusions: the early relapses in breast cancer, which are the majority of relapses, consist of surgery, surges of angiogenesis, and single cell activation. They're triggered by primary surgery. Late relapses are apparently not triggered by primary surgery. The Forget data, retrospective data, suggests perioperative NSAID ketorolac reduces early relapses by 5-fold. This still needs to be confirmed. This may reduce cancer mortality by 25 to 50% at low cost and toxicity. There are mixed reports of excessive bleeding after surgery, but this can be reduced with tranexamic acid, reduced by 39%, and referred to a paper by Allison et al. In 2015. So these data suggest that transient systemic inflammation is the precipitating factor resulting in angiogenesis and growth of single cells in dormancy. And while breast cancer runs its course in over a decade, most of the events that lead to relapse seem to occur in that post-surgery week. And this says that metastatic progression is amplified 100-fold during that 1 week post-surgery. Protocol is published for a way to prevent this, the McKelly et al. And there was a second retrospective study done by Belgium group, published Desmet et al. In New England Journal of Cancer, JNCI, Journal of National Cancer Institute. So after 2 retrospective studies, extensive clinical analysis, and 2 mouse models, we think it's time to conduct 1 or more prospective clinical trials with triple-negative breast cancer. We are planning on doing a trial at Beth Israel Deaconess Medical Center at Harvard with Ted James, who is Chief of Breast Surgical Oncology. Cost is a real problem here. The cost is so inexpensive, that's been a barrier to us. Drugs cost less than $5 per patient, and there are 2 million new breast cancer patients per year in the world. So for a lousy $10 million, we could prevent these early relapses every patient in the world. So there's no money in this. That's why we've had trouble getting funds to do clinical trials. The surgery-induced effects are apparently host responses to surgery and little or nothing to do with the cancer cell genotype and not the fault of the surgeon. And this seems to be a general effect based on some recent retrospective studies. Perioperative NSAID ketorolac apparently works in ovarian and colon cancers. These are my colleagues. The upper left, I'm standing behind Rick Rogers, Pat Wood. Pat died a year or so ago. She was the wife of Bill Retsky. Sitting next to her, Bill was my medical oncologist. Sitting next to Bill is Romano Demicheli. Above Romano is Panuccia Valagusa from Milan, the database manager. And to her left, to our right, is Gianna Bonadonna. He died also a few years ago. He was the first person to use multiple drugs and adjuvant chemotherapy in breast cancer. To the right, the larger picture is Patrice Forget, the anesthesiologist. Vikas Sukatmi, who was right next to Patrice. 4 gentlemen in the center picture, myself on the left, Romano Demicheli, Jane Vieta, and Isaac Gukas. J.N. is a surgeon. Isaac, of course, is dead. He was a surgeon. To the lower left, Osaro Erhabor. He is my main contact in Nigeria. I've visited Nigeria 3 times in the past few years. The lower picture with 3 gentlemen. To the left is Mike Baum, a retired surgeon from UK, Isaac Gukas, and myself. And to the far right is Judah Folkman. I was on Judah Folkman's staff at the time this project was underway. Thanks for your attention. I'd be happy to take questions.
Thank you so much, Dr. Michael Retsky, and it had been a wonderful speech, a study and analysis that can prevent the oncology linkage for the relapses that can happen due to operations. And I would like to open the